of follows in the footsteps of what was said by Peter Stutz earlier this morning. And so I actually just want to quote him a little bit, him and Thomas Kuhn, who inspired him. So before mass market adoption and prime time, according to Peter, bioelectronic medicine is actually is in the midst of paradigm shift. And according to Peter, and I completely agree, so this practice of neuromodulation, as we know, it needs to change in significant ways, including miniaturization, minimal invasiveness, closed loop, earlier intervention, personalized approach, and consideration of multiple targets. And finally, combining science with technology, with medicine, and with VC capital in reimbursement. So those all kind of interesting topics to discuss, but obviously we don't have time for all of this. So I also want to quote Tommy Natali, who said early this morning, said we're moving up in the complexity curve, which kind of also a nice segue into what I would like to show. So first, as was mentioned, we are publishing this report as of last 5 months. Can you probably see it on the screen now, Bioelectrics Business Report, which one of its topics is technology. We're also talking about applications, but in terms of technology, there is a few things were covered in the last 5 months. And just to refresh your memory for those who read it, we talked about neural loop with their multi-channel cuff electrode for VNS, Inervia in-brain for the graphene electrodes for VNS and vagal recording, Cardionomic about the pulmonary artery stent for stimulating cardiopulmonary nerve. And this year, last 3 months, we talked about University of Tübingen new test for VNS efficacy based on frequency of gastric EMG. Galvani, their new cuff electrode, which goes around splenic artery bundled with nerves. So you can see that picture on the right here. Nioxa, their leadless IPG GE, focused ultrasound. Leonard Ventures, combining bioelectronic medicine with cell regeneration therapies. And Valencia Technologies, coin-shaped IPG. So these are some of the topics that might be also being replayed at our discussion. But we will probably focus on just a few of them. And so let's start our session. So let me go to the next slide if I can, 1 second. Yeah, so these are 3 people who will be talking today, including myself from Edipace, Hannah Claridge from Technology Partners, and Maron Bixon from City University of New York. So with further ado, let's go to Hannah. Hannah, can you say a few words?
I can, via your screen and your microphone. I'm afraid mine isn't working. So yeah, great to be here with you all today. Great to be here in person as well. So I work for a company called TTP, the Technology Partnership. And we're a technology and product development company which supports other companies in getting products out onto the market faster and more reliably. So we're, as I say, we partner with other companies. You won't see our products branded because they're taken to the market with our partners. Is all based in Cambridge, UK, able to kind of put together custom teams to support other companies in their R&D, throughout their R&D process. Happy to answer questions on that later. But I will hand over back to you for now.
Well, Maron.
So hi, everyone. My name is Maron Bixon. I'm faculty at the City College of New York, not too far from here. My lab does a lot of work on neuromodulation science, basic technology development. We do a lot of contract work for companies as well, especially interested in non-invasive technology. And yeah, it's a pleasure to be here.
I'll just say briefly. So we'll first talk about sensors, organ specific and specific. So the first kind of question to both Maron and what do you think opportunities will be in the next few years in terms of closing the loop? Maron, maybe.
Yeah, I mean that's a question that everyone I think here has thought deeply about already.
You're muted.
Am I muted? No, I unmuted. Can you hear me? Hopefully.
No, you're good.
I'm good. Oh, okay. I mean, one thing I think that's interesting to think about is, when we're sensing something, we're usually thinking about like a biomarker. And it's nice to take a step back and think about what we actually mean by these kind of biomarkers. I think that you have the simplest idea is that it's a biomarker of like it's like a clinical surrogate. It's like, I want to treat depression, so I have a biomarker of depression, right? Or I want to treat pain, and so I can measure pain and adjust stimulation accordingly. Those don't really exist though, right? If you can define that, you're doing great on your own. And I think on the other sense, really, when we're talking about biomarkers, we're often talking about like biomarkers of what NIH calls target engagement. So just a biomarker that you're stimulating what you think you're stimulating. So like you want to stimulate a particular nerve bundle. And so you're measuring from that nerve bundle to confirm that you're stimulating it. But in that case, the activity of that nerve bundle has nothing to do with the disease, right? It's not a biomarker that has almost any correlation or no correlation with the thing you're trying to disease, right? So I think that that's one thing when thinking about biomarkers and looking at different approaches, I'm always like, well, which one are you? And is there like a more elegant place in the middle? And I guess the other thing that is from a scientific hat that I always think about with closed loop is, how much of closing the loop is about mechanism, right? So if I think like depression is not enough glia, so then I sense glia, and I think that stimulation makes more glia. So you know what I mean? So that's, I mean, it's a naive example, but that's the notion of like, when we rationalize closed loop, how much of that is like, we have a scientific basis versus how much of that is like empirical, right? We just have some knobs and we're trying to adjust them. And so when I guess that's some big picture idea. When I'm looking at closed loop technologies, I'm always trying to position themselves in that space.
Type of G will be different for different indications. And as you, do you want to measure something? Do you measure it at its source, or do you measure some downstream effect, which might be easier to measure, particularly kind of less invasively, or something that's more closely aligned with an implant or a device that you've already got attached to somebody? So take epilepsy as one example. You can try to monitor seizures directly from their source, directly in the brain, or you can monitor them through the vagus nerve, or you can monitor downstream impacts of seizures, such as heart rate. What is the best way of doing that? That kind of depends on what you want to use it for. And there's always a kind of trade-off there between invasiveness, accuracy, complexity, cost quite often as well. So in terms of what technologies do I see kind of coming down the line, I think it's a very difficult question to answer, because it will be different for different indications and for different applications as well.
Great.
By the way, just on that point, it's interesting if epilepsy is one of those examples where we have a marker that is pretty close to the disease, right? It's like characterized by, supposedly, by this electrographic signal. And so we actually do have a measure of the thing that we're actually trying to control. And I'm wondering how many more examples there are of something like that.
It's a nice example where you can actually work through the whole kind of chain, if you like, whereas there's a lot of other areas where you can't get to that kind of deeper truth, if you like.
Yeah, well, I guess the only example that comes to electric medicine would be the bladder, because that's a relatively quick response. So there you can get a real-time closed loop. Now, another example could be potentially asthma, where you also have some closed loop real time. But in most other cases, I think it's much longer term. For example, if you're talking about inflammation, we're talking about weeks to months and so on. So definitely closed loop becomes more weak. Yeah, not real time. Great. Anybody wants to comment about sensors? If not, okay. Let's move on to the next topic. So next week, we will talk about wearable neuromodulation. As I will quote again, Tony Natali for this morning, who mentioned that his company, at least his VC company, is interested moving away from potentially simulating nerve directly. So what do you think about that? What would be our other targets, whether perhaps we can stimulate some sensory endings on a scan or some other locations, and whether that will drive, what will drive adaptation of non-implantable neuromod? Is it safety, efficacy, convenience, cost? What do you think? Or something else?
Yeah, so most of my work is in the non-invasive space. So there, obviously, it's wearable is like the sexier term for it now, right? But it's always just been non-invasive, right? But you wear it on your head. you stick it to your back. All non-invasive is, well, I shouldn't say that. There's non-invasive that's wearable, and then there's non-invasive that's plugged into the wall. So you're certainly not going to be walking around with that. With non-invasive, obviously, you're always concerned about targeting. That's why you implant stuff, supposedly, right? If you could be so in the non-invasive space, you see a lot of activity about how can we be non-invasive and targeted, right? That's where you'll see like the big papers come out. Oh, we can be non-invasive and deep. We don't need deep brain stimulation anymore. Well, maybe not, you know what I mean? But that's where a lot of the excitement. So you see technologies like ultrasound that are making a lot of interest. That's where you're seeing that as well. But there are also technologies that are not very spatially targeted. Like I work on transcranial electrical stimulation, where you can try to make it targeted, but you're often stimulating large tracts of the brain. I think one theme that has emerged there, which I think could also be used for invasive, is that you're combining neuromodulation with some sort of task or some kind of activity. And it's that synergy that gives you the specificity. So for example, if you want to treat aphasia, you know what I mean? You might be doing stimulation at the same time as some kind of training, right? Related to that, some sort of word game or something else. And so you could almost stimulate the entire brain, but you're sort of priming the brain in a selective way to be adaptive to that. And the thing about wearables is, or non-invasive in general is, you actually don't want to wear it all the time, right? And so when we're really talking about wearables and stuff like that, another big contrast with invasive is you just cannot be on all the time. People are not going to accept it. So you're always looking for a lasting benefit, right? Something that hits and then produces a lasting benefit. And so, I know those are some high level thoughts.
Yeah, I think that's a really kind of good reminder to us that actually there are benefits both to wearables and implantable devices, depending on the use case. So clearly have a market to many more potential patients who might benefit from something, even if the benefit might be slightly smaller, and some people aren't to be able to undergo invasive procedures or aren't going to choose to undergo invasive procedures. So it's depending on the indication. And there's an increased user burden. People will probably see you wearing it. You need to remember to put it on, take it off, charge it, get it in the right place if you're targeting a particular part of the body. And actually, if somebody has quite severe symptoms and a disease, they may be willing to undergo an invasive procedure in order to then kind of be able to forget about it afterwards. Think about the classic example of a pacemaker. It's kind of fit and forget. Once, yes, there's an invasive procedure, there are risks associated with it, but once it's in place, you can kind of go about your life as usual without having to worry about it all the time. Contrast that with something like diabetes, where you've got a wearable, but you're constantly having to look out for it and kind of act as a result. And I think one other comment I wanted to make was actually around a middle ground of something that's minimally invasive. So advances Synchron making with their Stentro, just as one example. There are other companies as well doing somewhat similar things where you're trying to find a bit of a sweet spot, a bit of a middle ground between high efficacy, but also, so what can you do so that you can kind of inject a material, whether it's in the peripheral nerve, so that you can reduce the surgical risks, perhaps not to zero, but you can substantially reduce them. Similarly, there are numbers of companies working on implantable devices that don't contain batteries anymore, so that are externally powered batteries that kind of continuously topped up during the day. And I think that's a really interesting space that I'm kind of seeing more and more people thinking about is there a trade-off? Is there a middle ground where you get most of the benefits of invasive devices, but also some of the benefits of wearables to kind of make device easier for users, for patients, and to reduce some of that burden.
Anybody else from the audience wants to comment on
piggyback on something you said?
Yeah,
I think the notion of
your
I think what's more effective is interesting, right? We sort of have to say that invasive is more effective, Because otherwise, other than whatever, some business reason, well, how could you possibly justify it, right? But I wonder, it's like, maybe not, right? You can certainly think of examples where you have like TMS for depression is unbelievably effective for some people in a way that maybe some other invasive technique may not be. So, I mean, I'm saying I agree that it when it's used, it's more effective because it must be in order to justify it. But I know if it has to always be that way for every, yeah.
Completely agree. If you would take example of, let's say, Cyberonics or other companies working on, like Livano working on vagus nerve versus auricular devices, which is plenty of companies. There is a trade-off between cost, utility, efficacy, and adoption. So there's all these things are at play. Yeah.
Victor, I have a question I wanted to throw at any of the three of you, if it's okay. Is there any opportunity for a combination of a wearable or a non-invasive device with an implanted device? So I'm thinking, is Manfred here from, he's not, okay, so we're gonna hear from Manfred Frank later from Neuronif, who I think is an interesting example of this. I don't want to steal his thunder, but are there other opportunities where there might be synergy with a non-invasive or wearable device coupled with an implanted device, and if so, what would be the rich opportunities for those?
I can jump in to start with and say I think yes, I think there is. I think cases where you do need to be very close to the target site, which is not all indications, as you said, but cases where you want to be very close to the target site, but perhaps you're limited in terms of the space you have, and you may not want to have a long wire moving to kind of a chunky IPG with a battery in it. Perhaps you're around joint regions is a particular challenge. So I guess pain would be one indication. I'm sure there are others. I'll perhaps leave others to talk about the indication side of it. But yeah, I think there's definitely an opportunity. Most of the space that's taken up in implants is batteries. So if you can remove that battery altogether and just have the kind of targeting site, if you like, the electrodes or whichever technology you're using, and can then externally, whether it's through ultrasound powering, there are various technologies that could be used there. Then you end up having your battery is external, that's the wearable part. So it will only work when you're wearing the wearable, but you can still have the advantages of more targeted, more specificity of the stimulation.
And I guess a good example of company moving in that direction would be SetPoint, which is trying to reduce the battery. So if we take that to extreme, they could have like no battery and they would have to wear a necklace all the time, or would have a super cap, would only stimulate for 5 minutes, something like that. So I guess, yeah. Right, perfect. That kind of brings us to the next related topic, which is when we have wearable devices, of course, we're gonna have smartphone apps. And what would be the purpose of these apps? How can this big data can be utilized? So two ideas that I have in mind. One would be monitoring disease progression in order for us to apply the therapy timely. And second is monitoring different physiological states. So for example, if your device is, let's say, only necessary after eating food, because it's, for example, for treating GERD or some other GI related disorders. So then you want to monitor physiological conditions, like you want to know when you're eating or just ate recently. So what do you think about use of smartphones and apps for that, different purposes?
I mean, all the examples you said are good. You know, they sort of fall into that closed loop, right, analogy. So anyways, everyone's thinking about combining somehow this thing called digital health, right, with neuromodulation. I think a lot of examples I've seen or have worked with, they kind of like, you know, they scotch tape them together, right? So you're doing telemedicine, you know what I mean? And you're doing transcranial direct current stimulation at home. You're monitoring heart rate variability, and you're not necessarily closing the loop, but you're using that somehow later on as an outcome of interest. So as you're pointing to, there's a lot of activity already, right? There's invasive companies that now set up ways to remotely program their devices. But all these examples seem to mean like they're not necessarily something very new, but they're combining two very well-known things. And it'd be interesting to think of things that are, does that make sense, that are truly, that are not just combining known technologies, but maybe doing something very special that would integrate them?
Go ahead.
I think on digital health, there are different ways of defining what that is as well. So there's one side which at various points has been called big data or AI or kind of algorithm development, which is the kind of software layer that sits in between collecting data from a sensor and then applying some sort of other therapy. So how do you close that loop? There's an algorithm piece there. Whether that sits on your smartphone, whether that sits in the cloud, whether that sits in a chip on the device, almost doesn't matter. The algorithms might look slightly different, they're different constraints, but in all those cases, there needs to be something that kind of takes an input from a sensor and creates an output for a therapy. There's kind of then the other side of it, which is the patient engagement. What does the patient see? What do they interact with? So to your question around kind of smartphones, I think where there is a benefit to patients interact therapy in some way, whether that's to drive adherence for a wearable or whether it's to kind of be engaged in the therapy itself and to kind of make changes. So if you have a pain device and your pain is different or your Parkinson's is different from one day to the next and you want to be able to manually make some changes to the therapy, then it makes sense that you're going to need to be able to interact with it. And a smartphone is a very natural way of doing that. So rather than at the moment, a lot of patients have kind of handheld devices that they have to carry around in addition to their phones in order to make those changes to their treatment. So incorporating inputs that are needed from patients in that way into their smartphones, I think is a really nice of engaging patients in their care. It's not always necessary. There are plenty of areas where actually it makes more sense to kind of close that loop without the patient in the middle of it. But there are also plenty of cases where the automated closed loop isn't good enough yet, and you want to perhaps give patients the ability to override the default parameters within limits that are set by their clinician.
Very interesting. So essentially using artificial intelligence to inform natural intelligence when to close the loop. I see. That's interesting. Well, let's hope our patients have natural intelligence to close, because sometimes you need physician input for that. But yeah, I guess for some disorders that like depression and others, where it's very subjective anyway.
And in reality, probably the patient input will perhaps be which of these 3 or 4 preset parameters would you like today, or do you want to dial something up or down slightly within bounds that have been carefully set by a clinician previously. So I don't think a patient would or should have access to the same set of parameters, but being able to titrate the dose perhaps from one day to the next, or when they're doing different activities, when they're doing sport versus when they're lying in front of the TV, that those are different physiological states which a device may not be able to know about without input from the patient.
Absolutely. Yeah, let's open this for discussion. Anybody has comments about the smartphone uses as AI, big data? Do you have a microphone? Can speak into?
Maybe if you can repeat the question, like I'll say it, but it's what is with pharmaceuticals, we send so they have access to that bottle of pills no matter what the physician prescribed. So, what I'm hearing is app-based, you can put more controls on the app and put parameters in there. So there also some control. And I think that that's just an important thing to mention.
Yeah.
Thank you.
Okay.
By the way, that
Yes.
brings another interesting point about, we talked before about, pharma versus with drugs, there's some room to play, but the play is maybe I'm going to skip my pill today, or I'll take 2. but like you can't mess with the, you make a tiny change in the chemical composition of something and it can go, it can become fatal very quickly. With neuromodulation, we have a play over a much broader range. And so if you're talking about personalization, you theoretically could provide 1,000 doses with one neuromodulation device if we only knew how, right? So it's like giving them 1,000 pills, but
and it's less binary. It's not one pill or two pills. Two pills or three pills. You could have 1.5, or you can actually have more.
Or you can have a blue pill or red pill. Right. Okay, great. Thank you. Let's move on to the next topic, which is something that Marom, I think, can lead on, which is subthreshold stimulation. So would you like to say?
Yeah, just really quickly. I mean, subthreshold is sort of defined by what it's not, and it's not super threshold. Super threshold stimulation is what most people are familiar with. And it's, in my mind, it's just defined by delivering pulses where the purpose of those pulses is to generate action potentials in some structure. So you're applying 100 hertz to the vagus nerve. You're assuming that you're going to produce 100 hertz action potentials in the vagus nerve. And yeah, that's going to lead to some very complicated secondary effects, but it's pacing. So subthreshold is not pacing, right? So it would be almost any technique where you're not sort of simply driving action potentials. And it used to be that subthreshold was sort of relegated to like either very low intensity, right? Or very low frequency waveforms like DC, where just pacing wasn't an option. I think recently there's been more excitement in subthreshold because now it seems to be like a great example would be 10K for spinal cord stimulation. You're not supposed to be able to produce pacing at 10K, right? So it shouldn't work. First of all, it does, but so we're going to like frequencies like that, and so that, for example, brought up interest in subthreshold, even though it's very high intensity. It's actually mega high intensity, right, compared to regular. Or interest in non-neuronal cell types. Why do we not stimulate glial cells? Well, we do. Why do we not stimulate endothelial cells that form the vasculature? We do. It's inevitable. It's not possible to not stimulate, but we don't like to think about. If you think about pacing, stimulating the blood-brain barrier is not interesting, right? But so I think also when you're moving to these new cell types, so now what you'd call subthreshold is becoming relevant for DBS and and SES and VNS and all these other things. And so it starts to blur the line of what, so these are subthreshold mechanism-y things that are now, I think, becoming interesting to a wider audience. My take on it is that it's happening, but it's ignored. So you cannot stimulate the body without stimulating. These cells are not inert to electrical stimulation. I just don't see how you can apply a lot of electrical or any kind of energy to part of the body and not change vascular function. In fact, we know you do it because we image it, but what does everyone say? It's an epiphenomenon, right? Of course I stimulate and I see a change in blood flow. That's great, but it's not the thing that matters. And again, every time people have looked at glia and they've applied energy to them, they see the glia respond. So my sense is like it's there all along. It just people are just starting to kind of carve.
We're renaming this. So we're renaming this from side effect to secondary effect
or primary. You never know. It depends who you're selling the grant to. Yeah.
What applications are you applying that to, or are you thinking of applying that to?
So one application I'm very interested in transcranial stimulation using direct current. We found out that has it can do something called electroosmosis through the blood-brain barrier. So you can drive water through the blood-brain barrier. The ability to put something on your head and for just a few minutes, essentially flush the brain, opens up a lot of very interesting potential applications for why certain disease states. So that's just one example where, but at the same time, this technology is already being trialed for dementia and other things. So that's what I'm saying. In many cases, I feel like it's often like the applications are there. We don't need to redesign DBS. It's just more about the mechanism saying, okay, maybe DBS, it's not just a glial scar. Those glia are somehow part of the body's response that is then explaining outcomes. It opens up a lot of fun places to play as far as ideas. And then, of course, you can try to design interventions. Of course, you can try that. There's been some recent activity, right, where companies, for example, have proposed technology that might specifically stimulate glial cells that might be relevant for pain. And so once you start thinking about these cell types, you could optimize for them, but I don't think I think you're stimulating them anyways, so you don't have to.
With Chris Kuleo at GD Labs, where they basically, he said that he discovered essentially that ultrasound acts primarily through mechanosensitive receptor ion channels on the axons. And then in the same podcast, they also interviewed Hubert Lim at University of Minnesota, who followed up by saying that functional ultrasound indeed stimulates these mechanosensitive ion channels, but it produces only depolarization of axon, not necessarily action potential. Therefore, what it creates is an interesting novel phenomenon where we can stimulate unmyelinated axons, which, as we all know, roughly don't generate action potential. Essentially, it's a traveling wave of depolarization. Versus myelinated axons, which require action potential. So maybe focused ultrasound is a novel method of selectively activating unmyelinated axons, which would be amazing because right now something we're lacking is electricity. We cannot do that selectively. So just your take of how important is this for the field if this is in case true, and what else you see exciting about focused ultrasound?
I can give you, maybe I'll start with an unpopular opinion. I guess, I don't work in focused ultrasound, but one concern obviously is heating, right? I mean, focused ultrasound, for example, can be used very effectively to produce ablation in deep brain targets, and there's companies that make it for that. And so I'm saying it's unpopular because many people who work in focused ultrasound don't want to think of heating as the mechanism of action. However, I don't think that's a bad mechanism of action at all, right? If you could produce a local focal heating that is non-injurious, and then that leads to an effect. And the thing about temperature changes, they're very slow. So if you're seeing for me, when I'm seeing outcomes that seem to have a very slow onset and a very slow washout time, it further raises the concern that, you need to be very careful about ruling out heating. Having said that, there's many people who work in the field who have very aggressively work to rule out heating as their mechanism of action. And so, for example, they focused on these some sort of ion channel that responds to shaking. You know what I mean? Or maybe everything responds to shaking. So I would that's my one qualification for otherwise an area that obviously has garnered a lot of excitement again for this notion of non-invasive deep, right? And now you're talking about something else, which is cell type targeting. You may not be able to get with other techniques, right?
Yeah, I think at the moment there are plenty of hypotheses as to the mechanisms of action of ultrasound. Some are kind of getting increasing levels of evidence, but I still don't think we're at the point of being able to say for sure that we really understand what the mechanism of action is, or exactly how it's impacting the neurons that it's stimulating. So I don't think I have much more to add beyond what we were saying earlier around there are kind of different pros and cons of having more or less invasive or targeted stimulation for different indications. And I think what I find interesting about the ultrasound side is the fact that it has a different, it's different to the electrical stimulation that we usually see, and therefore it kind of opens a new door with new potential opportunities there that are different and that may be more applicable to some indications that are not particularly well served by the electrical stimulation that we usually apply.
Great. Anybody wants to comment on the ultrasound?
I think a good question on the heat that's being generated in ultrasound, or even as was proposed during the 10,000 hertz, are we actually creating a heat effect? And so I guess some of the questions would be: has anybody researched what kind of heating is caused, or what kind of neural interface is happening with heat?
So again, I don't primarily work at ultrasound, but I know people who have worked very hard to rule out temperature. For example, you can do MRI thermography, right? And they'll do things like that to really try to rule out temperature. of course, there's also the thing that ultrasound is not one thing, just like electrical isn't, right? So one group is ruling out temperature, but the other group is doing something very different in a rodent, where it might be. But I do think that temperature is we all use, heating, cooling, and we're all aware that it has therapeutic actions. And so if it was heating, again, for me, it's not a terror that that's what it is. It's just, I think temperature rise could be like you said, for 10K would be another example where when you're with implants, right? Again, no one wants to talk about it, but the more energy you pump in, that's going to produce joule heat inevitably. So you're going to be producing some heat. Maybe it's a little, maybe it's a lot. In either case, it could be something that's embraced. It's like you're planning a little micro heater, and you're just kind of warming things up a little bit.
And to that point, I mean, there are at least one company, Thermoquil, and is using thermal neuromodulation for pain, where they modulate between very high heat and low heat to treat pain. So I believe there's more than one company that's doing that.
Okay, thank you for these. So we kind of covered the key topics we wanted to cover. So I'm down to my last question, which is okay. So it will be a little bit provocative and very personal, I guess. So let's take a short scope of time, 1-2 years ahead of us. So I'll give you a couple of things that might be happening in the next couple of years and ask you what do you rank them as the most interesting to you. So one of them could be completion of the SetPoint trial in the US, which I think will bring us to the first successful bioelectronic medicine therapy. Second would be publication of, let's say, 1-year efficacy results and safety data from Galvani on their new cuff electrode. Third could be a closed loop BNS by either Neuraloop or Inervia, companies working with Merck right now. And lastly, let's say GE showing the results for functional ultrasound for either COVID or type 2 diabetes. So one of those, which would be most exciting to you?
Should I unmute mine or?
Actually, I think yours was coming in pretty good, so go ahead. Unmute.
I don't want to, I'm not going to pick horses for technology, but you mentioned something I do care a lot about, which is COVID and also long COVID, or what's called neuro COVID. And I just think that there is so much potential to just take the technologies we already have, no need to modify them, and trial them, right, for neuro COVID, which is complicated, but it has all these symptoms like pain, fatigue, lack of focus, that many depression that we're in some cases already targeting. Again, I'm biased, but I think it is. You hear estimates that 1/3 of the people, right, who get COVID develop persistent, which is a crazy number. 1/3, including asymptomatic. Maybe it's not 1/3. Fine. So we'll take 1/10. Right. It makes it it makes this sort of a public health crisis like nothing else we've ever seen. And so I think it's wonderful that we already have, and some companies already doing this. We have tools on deck, and there are trials now running, both in the acute case, there's some emergency uses, but also in the long COVID case. I think it's a wonderful opportunity for maybe neuromodulation to rise.
I think for me, what's most exciting almost is the fact that you were able to list 4 different trials there that are all in that translationary phase where they're doing those clinical studies and where the results could be coming through soon. So I almost feel like even more exciting than any one individual trial is the fact that there are multiple trials like this going on at the moment. And I think that kind of suggests that this is a really exciting time for a really exciting industry, and I'm going to be fascinated to see the results of all of those trials over the next year. So a bit of a non-answer there, I'm afraid, but I think they're all really exciting.
Sure. Thank you so much.